The subcostal window. I sometimes call it the forgotten window because it's underutilized. Definitely, the subcostal window should be a part of every exam. Where is the subcostal window? Well, it's below the xiphoid, where you're imaging from the abdomen towards the heart. The main advantage is that you have no ribs, you have no lung, and you have no sternum to obscure the view to the heart. So it's actually ideal for patients who are immobile, where you cannot turn them to the left, patients who have COPD and where especially apical window is obscured by the lung, in patients with a very steep axis of the heart. In this case, the heart is kind of hidden behind the sternum and you can only see it if you image right from underneath the sternum. Use it if you have poor image quality, or actually always use it, because you will be surprised. Very frequently you will get the best image quality actually from a subcostal window. I already mentioned that you should use it if patients cannot be positioned in the left lateral position, because you don't need that from a subcostal view. And in some pathology you will have to use it, especially if you have pericardial effusion, because that's the view where you can best assess the size of a pericardial effusion. Same is true if you want to image the IVC. There is no other view where you can get a better appreciation of the IVC than from a subcostal view. The interatrial septum is nicely displayable because you have a very perpendicular orientation to the heart, and you can even look at the flow across the pulmonary artery. We're going to show you all of these advantages in this lecture. But first, you'll have to learn how we actually find the heart from a subcostal window. In most patients, you will need to put the patient on his back. Sometimes it's of advantage if you angulate the knees because it reduces the tension of the abdomen. In reality, however, you can even perform subcostal views of patients lying on their left or even on the right. And to be honest, I never really raise the legs or angulate the knees. Now, when you image from a subcostal view, the first thing you have to do is orient yourself to the heart. So you first place the transducer in the xiphoid region with the transducer or with the marker to the lateral position. And then you aim towards the left shoulder. And while you do this, you let the patient inhale. What you will nicely see here is that we're actually using the liver as an acoustic window. And if we place the transducer so that the marker is on the lateral side, you will get a 4-chamber view. More on the 4-chamber view in the next demonstration. But before we talk about the 4-chamber view, let me give you an overview of all the different planes that we can image from a subcostal view. With the 4-chamber view, again, we're cutting through all the 4 chambers of the heart. The only difference to the apical 4-chamber view is that we are coming more from the right opposed to the apex. That's why the septum will also have a different position. You'll see that then in the demonstration. Then we have the long axis view. This is the view where we're imaging the IVC and also the SVC. We're transversing the heart in this direction. And then the subcostal short axis view. By rotating the probe, we can get a short axis view at any level that we wish, at the base, at the mid, and even at the more apical parts of the ventricle. Now to the 4-chamber view. Now let's take a closer look at the 4-chamber view from a subcostal window. You will see that it looks quite similar to the apical 4-chamber view, only that the septum is now oriented more towards the right. This is clear. We're now imaging from medial position. You have the left ventricle here and the right ventricle right here, closer to the transducer. This is the right atrium, and here we have the left atrium. Now, very frequently you cannot see the apical structures because you have gas. So the subcostal view is usually not ideal to really image the supraapical structures. But you can use variants of the 4-chamber view by just rotating and also tilting the transducer. Thereby, you can even display kind of a 5-chamber view. Here, you would have the aortic valve. The 4-chamber view is ideal to also image the intraatrial septum. This is a structure which is very important if you're looking for atrial septal defects. And in the subcostal view, you have a perpendicular orientation actually to the defect. This is why the subcostal 4-chamber view is one of the most important views when you study atrial septal defects. But that will come in the chapter on congenital heart disease. As a short review, we are seeing all 4 chambers. The right ventricle is the one which is closer to the transducer. We can see the peri and epicardium very nicely here below the liver, and we have a very perpendicular orientation to the interatrial septum. This is a subcostal view in a healthy individual. Right ventricle, right atrium, left atrium. Note that there is no gap between the liver and the heart. And if we now look at the different pathologies that we can look at with the subcostal view, we've got the right ventricle here, where we're looking at the size, function, but also at the thickness of the free wall. The subcostal view is one of the best views to look at right ventricle hypertrophy. You see here some degree of RVH which is present in this patient. And then the interatrial septum, we have a very parallel orientation, as already mentioned several times. And here is the corresponding color Doppler of a patient who has an atrial septal defect, where we see flow from the left atrium right into the right atrium. A very parallel orientation, ideal to image. Another very important reason to perform a subcostal 4-chamber view is the detection of a pericardial effusion. Now we do have a gap between the liver and the heart. This is the diaphragma and also the pericardium at the same time, and this is the echo-free space. We do have some structures which are on the heart. This is epicardial fat, but this here is the pericardial effusion. And we can also look at pacemaker leads. This view is ideal to follow the pacemaker leads as they go through the tricuspid valve into the right ventricle. Now let's turn to the next very important view, which is the longitudinal view to detect the IVC and also the SVC. There are several approaches to image the IVC. I would prefer to use the one where you start from a 4-chamber view, a subcostal 4-chamber view. From this view, what you need to do is you need to move the transducer, pointing it more to the right, and while you do so, also rotate so that all of a sudden you see the IVC as it enters the right atrium. Remember, we now have an orientation of the IVC which is in longitudinal direction, just as we have the transducer oriented, and we are a little bit more to the right of the midline. Here you see the IVC, and if you move the transducer back and forth a little bit, also the hepatic veins, how they enter the IVC. By moving the transducer back and forth a little bit, you are also able to visualize the SVC, which comes from the cranial side, from the distant vicinity of the image into the right atrium. Right here would be the SVC. There might be several situations where it is not so easy to really get a good subcostal view, especially if patients have tense abdominal muscles or if they have a little bit of a beer belly. Still, if you use the typical motion I showed you in the demonstration, where you kind of use a screwdriver motion, rotating towards the left and counterclockwise, and then of course adjusting the tilt so that you get into the IVC, I'm sure you will get a good view in most of your patients. I want to show you how to find the IVC again on the simulator, because there you can nicely see how the anatomy fits to the cut plane that you should acquire. How do you display the IVC? Well, simply by rotating towards the right, so more towards the liver, and tilting the transducer, and at the same time rotating, and all of a sudden you will see the IVC as it enters the right atrium. Now, for those who want to become experts, there's even a way that you can see the SVC. You need to just tilt and turn the transducer a little bit and just follow the IVC, and the continuation of the IVC is actually SVC, which can be seen right here. Let's review the structures we see in the longitudinal view once more. We've got the IVC, which might be difficult to detect if it's very narrow. We've got the hepatic veins, which enter the IVC very close to where the IVC actually reaches into the right atrium. We've got the SVC, which is the continuation more or less of the IVC. If you're not sure what you're seeing, use color Doppler, then you will see the inflow from the SVC as well. And in some patients, you can use this view also to detect a pleural effusion, a right-sided pleural effusion, which would be visible right here. What are the clinical indications for this view? Well, basically to assess the size of the IVC, which corresponds to right atrial pressure. and also to look at flow in the hepatic veins. Take a look at the width of the IVC in this patient and compare it to this patient. I guess it's easy to see that the IVC is massively dilated here. So this patient definitely has elevated right atrial pressure. Note also that the hepatic veins are dilated. But we can also see other pathologies. A tumor, for example. This is a hypernephroma, which is growing along the vessel, reaching into the right atrium. Know how distended the IVC is because the tumor is expanding the vessel. And here is a pleural effusion. I mentioned that already. This is part of the lung that you're seeing here. And in addition, we see the IVC and the hepatic vein right here. Note that we're seeing some spontaneous flow here. This is not a pathology. The venous flow is generally much slower than the arterial flow, and with 2D echocardiography, especially if we're using high image frequencies, we can actually see the spontaneous flow. But now, let's turn to the short axis views. Sometimes you do come into a situation where the only image window you have is the subcostal view. And to demonstrate all the structure of the heart, you have to be creative. And as a matter of fact, there is more to the subcostal window than the 4-chamber view. Let me show you. Let's start with the 4-chamber view, however, and then rotate the transducer. All of a sudden, you will get a short axis view of the left ventricle. Now, this short axis view looks very much like the peristernal short axis view, with the right ventricle right here and the left ventricle right here. So here you can actually assess circular or radial function of the left ventricle. And you can scan the ventricle by going back and forth from the base to the apex. In addition, if you rotate or if you tilt the transducer a little bit more to the right, you will get a view that you also know from the peristernal window. It's kind of a short axis view, again with the aortic valve here in the center of your image, and the pulmonic artery with the pulmonic valve right down here. This would be the bifurcation, the right and the left pulmonary branch. This, as a matter of fact, is my favorite view if I really want to assess the flow signal across the pulmonic artery. You see how nicely this can be performed? You put the transducer right here, and you will often get a fantastic image quality of the pulmonic artery. So be creative when you use the subcostal view, and also use the short axis views to demonstrate the entire heart, just from a subcostal window. So remember, we have to perform a fanning motion perpendicular to the axis of the heart, starting from the base down towards the apex. And that way you will get a view which looks like this if you're at the base of the heart with the aorta as the central structure, the pulmonary artery, the pulmonic valve, the right ventricular outflow tract, the tricuspid valve, the right atrium, and the central structure here is the aorta. Frequently, you'll also be able to see the IVC here. So a view which is very typical to the peristernal short axis view. So why is this view important? Because we want to assess pulmonic flow. There's probably no better way of looking at pulmonic flow than from the subcostal view. I even prefer this view, if it's possible, to the peristernal view of the pulmonary artery. Here we can detect stenosis, here we can even perform shunt calculations, we can look at the acceleration time to detect pulmonary hypertension, and much, much more. In addition, note that the aortic valve can even be seen here in a short axis so that we can assess the opening motion as well. Take a look at this view here. Now we're applying color, and we see a turbulent flow here at the pulmonic artery and at the pulmonic valve. So this denotes pulmonary stenosis, a beautiful example of what we can do with such a subcostal view. When do we use the short axis view at the level of the ventricle? Well, to assess left ventricle function. You nicely see the septum here. You see that this patient has normal left ventricle function. You can even detect the size of the right ventricle, determine whether or not it's dilated in relationship to the left ventricle. So this is a view that is very similar to the peristernal short axis view at the level of the ventricle, and the same indications apply. Now let's put all this together and let's take a look at all the different views you can get from a subcostal window. The 4-chamber view, the long axis view with the IVC and the SVC, the short axis view at the level of the ventricle, and the short axis at the base of the heart with the pulmonary artery. So what is the take-home message when it comes to the subcostal window? Most important, use it in every patient. Be creative, you can get a lot of atypical views, and don't forget that when we image the heart, we have to also image the vessels that lead to the heart, and therefore it's mandatory to look at the IVC. In the next lecture, we'll be taking a look at the suprasternal view.